to our system. But there is considerations for non-beta-lactam. You really should consider, though, some risk still for if it's a severe non-IgE mediated reaction. We did actually publish the results of this. If you were interested in seeing kind of more of what we did, but we looked at over 17,000 patients, about 8,000 pre-implementation and 9,000 post of removing this alert. And what we found is there was a statistically significant increase in the outpatient prescribing of cephalosporins, primarily cephalexin and cefdinir, by about 8%. Also, the use of alternate antibiotic classes decreased, and there was no statistically increases in adverse effects, which I think is most importantly what we'd like to see. And also to alert modification reduced by 92%, which is obviously due to alert fatigue. This was a very important finding. We also have done research and published our data on our obstetrics patients for the first 2 years of our that we started seeing them. We saw around 300 patients. I was able to delabel about 90% of these patients after undergoing an oral challenge or skin testing. And you can see on the figure on the right, majority of the patients had just an oral challenge. And there were some patients that, of course, did skin testing plus an oral challenge. No patients had an IgE-mediated anaphylactic reaction. And patients then were able to receive penicillin G, which is the bottom bar here, more often. So it was statistically more patients seen in our clinic than those not seen got penicillin G for group B streptococcus prophylaxis compared to those that were not seen in our clinic. And then I do want to provide, I was a co-author on a paper about non-allergist delabeling, and it was a pro-con debate on whether or not non-allergists should be able to delabel. And the take home here is that, yes, pharmacists are perfectly positioned to assess the patient's drug allergies. We make clinical recommendations. We verify orders and safety of prescription orders. We're trained to determine if an allergy label is accurate or if it's more of an adverse effect. And so we should be widely integrated within team-based care to provide that can provide penicillin allergy testing, drug challenge, and delabeling, which again is well documented in the literature. This is just one such protocol, and I know we kind of running low on time here, so I want to ensure that I get through this. But essentially, there are various ways to determine or assess allergy risk. I would encourage you to look at this. Is out of that article I just cited on the last slide. But essentially, we have a PEN-FAST score that we utilize to determine their risk, which is in the middle here. And if they are low or very low risk, these would be the patients that we would often recommend a drug challenge in. And I'm sure you have a protocol in place to do that. And it can be done as a 1-step or a 2-step challenge with observation, under observation for the clinic. And there are certain patients that you would not be a candidate for a drug challenge. Of course, patients with severe cutaneous allergic reactions, cytopenias, et cetera. And then pediatric world, there's a little less data on the PEN-FAST, but we do know if it was an isolated benign rash as a child that they actually could be challenged as well. So just some take-home points. I think the biggest thing as pharmacists is we can be positioned to take a detailed history on the drug reactions they have. And really this can be done through a simplified risk stratification form like the PEN-FAST. We can update those allergies in the chart. And that's the one thing I would definitely want you to do in your practice if you haven't done that already, is when feel comfortable is accurately put the year that it happened, the details of that reaction, and of course, delabeling when it's not an allergy. Educate your patients on what these implications are of having the label. Identify maybe a provider champion that's willing to partner with you to do some of these things. And then again, remembering that it's okay to use cefazolin for patients with penicillin allergy. And if interested in more of a system-wide changes in your EMR, working with pharmacy informatics on the opportunities to leverage your experience, our experience that we've had. And of course, reach out to me. I'm a resource now, and I'd love to talk with any of you about how you can utilize these things in drug allergy space. And so with that, I'm going to turn it over to Rick. I will stop sharing my screen.
Thank you, Deanna. I'm actually going to bring my screen up. Okay. Can everyone see my screen okay?
We sure
Hopefully.
can.
Thank you. All right. So, let me thank everyone who's here today or will be listening to the recording. So, my role is a little different from Deanna's. I'm actually a psychiatric pharmacist. I've been working in mental health for about 25 or so years now. But I'm actually based in a primary care clinic. So I thought it might be interesting to talk about how we might integrate. I'm in psychiatry, but another specialty type practice within a primary care setting. So again, really quickly, what is the need for this, for a mental health practitioner in primary care? So when we look at statistics, 1 out of 5 Americans has some mental illness at any given point in time. So that's 20% of people. So, copying Deanna earlier, I mean, looking at the number of folks in this session right now, that says that there are playing the percentages about 5 or so folks in this session right now that have a mental illness. And no, I'm not asking for anyone to raise their hand. When we look at some of the most common mental illnesses, anxiety disorders as a group, not any specific one, are at around 19%, and major depression is at around 9%. So if you think of your common medical illnesses that we see in primary care, that's actually around the same rates as patients living with hypercholesterolemia or type 2 diabetes. These are very common illnesses that walk in the doors of a primary care setting. So, having someone in that setting who is trained and ready to help these folks would seem prudent. So, getting to that question, why integrate psychiatry in primary care? So again, when we look at the rates of major depressive disorder, it's almost 10% in the United States, which is similar to type 2, the prevalence of type 2 diabetes. This just looking at depression alone, this is a common illness walking in the door of our primary care clinics. Getting more specific, 60% of patients with depression are actually treated in primary care, not in a specialty mental health clinic. And when we look at the total number of primary care visits, and these data are pre-pandemic, so most likely we're looking at much higher rates of all of these statistics since the pandemic, as we know the rates of mental illnesses, depression, anxiety in particular, have increased during and since the pandemic. But even pre-pandemic, 5 to 10% of all patients seen in primary care visits were presenting for a depression-related concern. 79% of all antidepressant prescriptions come from primary care providers. So, as I like to tell folks, we need to go where the business is. Because while the care is taking place in primary care, a lot of the time the treatment is suboptimal. Because, I tell my primary care providers that I work with, I almost feel bad for them. I have 30-minute appointments to just focus on mental illness. And if you've had a primary care appointment or if you work in primary care, you get about a 20-minute visit to do head to toe, fingertip to fingertip, and everything in between. You can't do the level of mental health care in 20 minutes in a primary care appointment that can be done in a more focused mental health appointment. So, lack of time and follow up appointments. Most primary care visits are spaced 3, 6 months apart, maybe even once a year. I routinely see my folks every couple months, sometimes shorter, sometimes longer, depending on the need. So, I have the availability to provide more frequent follow up care, which is often needed for these patients. And if you've heard of the term patient-centered medical home. This is been around for 10, 15 years now, maybe longer. This is a national initiative to bring care to the patient rather than the patient going to care as much as possible. And integrated behavioral health is one of the tenets of the patient-centered medical home. And the clinic that I work in is I believe we are currently a level 2 working towards a level 3 patient-centered medical home. So again, in a mental health setting, the focus is mostly, if not exclusively, on the mental illness and what meds and treatments are being used for those mental illnesses. Physical illness is a distant secondary concern. I jokingly tell folks I focus on the neck up. Anything below the neck is not my concern. Now, obviously, that is not the case. We know as pharmacists that everything is interconnected, that medications that patients take don't just go to the site of therapeutic benefit, they go everywhere in the body. I jokingly will say they're not smart bombs. They are nuclear bombs, and they will go anywhere and everything, everywhere, and hit everything, whether it's for benefit or adverse effect. So in a primary care setting, I still focus on their mental illness, but I have to consider their physical illnesses. I have to consider their entire diagnosis list, their entire medication profile, their labs, everything else, because otherwise we're not providing whole person care, which is the goal. So while my focus is on their mental illness, I look at the entire patient and the entire package that they present with. But I'm a psych specialist. So why am I worried about all these other things? Because we know that that's not the way it works with our patients. So, what are some of the illnesses that I work with and services that I provide? Pretty much, if you're aware of the DSM, the Diagnostic and Statistical Manual of Psychiatric Illnesses, most any illness in the DSM I potentially can treat. I only work with adult patients. I don't work with anyone under the age of 18. I do have a number of geriatric elderly patients, but pretty much mood disorders, as I mentioned statistically, some of the more common reasons that patients are referred to me, anxiety disorders as well. I have a number of patients with schizophrenia, ADHD. I'll get patients referred to me for medication related adverse drug events. So, someone is treating a patient with an antipsychotic and they need an evaluation for a movement disorder concern. They will send them to me. It might be a one off appointment or it might lead to an ongoing referral for care, depending on the specific need. So, a lot of what I do is direct patient care management. I have a collaborative practice agreement where I am one of the providers within my clinic. I receive referrals from the primary care providers, and once referred to me, I essentially am the patient's primary psychiatric provider. You noticed ADHD, Massachusetts, where I practice, allows pharmacists to prescribe control. So I do have a DEA number where I can prescribe psychostimulants like Adderall, Ritalin, etc. I also prescribe benzos for anxiety and other concerns if warranted. So pretty much anything related to mental health care is within my capability to work with. I do obviously evaluations both for symptoms and adverse drug events, as I mentioned. I do e-consults, so maybe the patient doesn't need to be referred, but the PCPs need some backup with a particular patient, which is fine because then they can continue managing the patient with me in the background, as opposed to a full referral that now takes, appointment time that could be provided for other patients. Some med reconciliation transitions of care. I actually had a patient just this morning that was supposed to meet with me after a hospital discharge, and I recognized we don't have their discharge paperwork, so had to get that, and in order to be able to provide appropriate care for that patient. And then I will refer for other services, therapy and counseling within our behavioral health clinic, case management for any identified social determinants of health, food insecurity, housing insecurity, anything in those lines. I am not trained to deal with those social determinants of health beyond identifying them, but I certainly know how to connect my patients with those resources to help them with those concerns. So, moving from a disease state management to a comprehensive med management, and I'm going to throw a quick shameless plug. I completed the ACCP CMM Academy certificate a couple years ago. I highly recommend it if you really want to learn how to expand into a true comprehensive med management full patient care model. It was an excellent program. I highly recommend it to anyone who's considering it, and I will end my shameless plug there. So, Particularly in specialty care, we often focus on disease state management. As I said, in mental health care, we focus on the illness. What is the diagnosis I have been asked to treat, rather than looking at the whole patient? What are the goals for that illness, not the entire patient? And we don't look at problems related to anything outside of our specialty area. Comprehensive med management, I now look at the whole patient and a treatment across their illnesses. Now, I was doing some of this before I completed the CMM Academy, but it really brought to light the fact that you cannot ignore those other aspects of the patient. What are their overall goals of therapy, including the patient's goals? So my goal might be to get their depression to a PHQ-9 score under 5. Okay, but what's the patient's functional goal? What is their social goal? And incorporating that into my treatment plan. And I focus on that illness, but I do consider other problems. And I'm going to give you a couple quick examples of how I do this. Utilizing that full knowledge base that we have as pharmacists. I don't just know about psych meds. I mean, that is my specialty. But I know the basics of diabetes meds and hypertension and cholesterol and asthma and so on. That's not what I treat, but as a pharmacist, I still can assist my patients with those other illnesses and the meds that they're using. So you can get there from here. How do we move from DSM to CMM? As I said, I was incorporating snippets of CMM into my practice prior to completing the certificate. Especially being in a primary care setting, you can't ignore the other illnesses that walk in the door with the patient. I was part of a team, but also on an island. A lot of the primary care providers said, "Oh, well, this patient has this mental health illness. I'm sending them to Rick or the other psych providers. Let them deal with it, not my concern." Now, in a CMM practice, I'm more deliberate in working with the entire team. More comprehensiveness, looking at that comprehensive med management, not just a disease focus. Going back to their medical providers and saying, "Hey, I met with the patient for a psych eval appointment, but they mentioned this." And incorporating my students. I'm a faculty member at a school of pharmacy. I have APPE students regularly throughout the year, and incorporating them into that practice. Doing med reconciliation, reviewing for med therapy problems, doing pre and post appointment outreach to patients. So providing, again, a more comprehensive service, both myself and the overall program that I'm providing. So this is just to give you a quick idea of how patients come to me and what I do with them. And this is just focusing again on depression. I could create similar charts for other disease states, but just to give you a quick idea. And as you look at this, just think about if you are in a little bit more of a specialty setting, or you want to provide a more specialty type of program within primary care, you can insert your own disease state here with their own parameters and so forth. So I get a referral. It's reviewed by the case managers to ensure that it's an appropriate referral. I do a 60-minute baseline appointment, do a baseline PHQ-9, which is a very common patient self-rating scale for depression. Most primary care clinics use it already. It's built into their systems. From there, we'll make determinations of what needs to be done. Do we need to make med changes, dose changes? Are there adverse effects that need to be dealt with? Do they have a therapist or need one? And again, I can get that referral established. I will also ask them about their other medications. So again, in that comprehensive med review at that baseline appointment and follow-up appointments, okay, so you just started a few weeks ago on a GLP-1 med. How's that going? Well, I'm having really horrible, nausea. I can't keep taking this med. My GI is doing backflips. I stopped taking it a week ago. I'm not going to do it anymore. Well, I'll send that message to their PCP because their PCP might not be meeting with them for 3 months. Well, why waste 3 months of no treatment when I can share that info with them based on my psych evaluation appointment? So I get that info back to their PCP, again, as part of that team-based care. And then moving forward, we will schedule follow-up visits that are 30 minutes based on the patient's need. Shorter if we're doing more acute work, longer follow-up periods if there's, more stability and so on. So again, as you look at this model, I know it says depression, but think about how this might work for your own specialty or clinical interest area. And yes, I am billing for my visits. If this is something you'd like to hear about, ask me how we do it. For purposes of this presentation, that's a whole other discussion. So, but if you're interested, please feel free to reach out to me to discuss. So, quick sample. I know. Again, we're running short on time. So, I had a patient referred to me for treatment of depression, quote unquote, not responding to SSRIs. And when I looked, the patient was on sertraline 50 milligrams a day. They also have several other comorbid illnesses. Initial visit, PHQ-9 is 23, which is severe. The max score is 30. Recent labs, A1C of 9.7 related to their type 2 diabetes. Read their progress notes, med lists, and patient response history indicate that increase to sertraline 100 milligrams a day was warranted, which the provider was not comfortable doing. So they refer them to psychiatry. We upped the dose. They also mentioned again that GLP was not going well. They stopped taking it, sent a message back to the PCP, make them aware. They set up an earlier follow-up appointment to make some adjustments in their diabetes treatment regimen based on the info that I provided to them. Follow-up visit 2 months later, their PHQ-9 has decreased. They're tolerating the new dose well. The GLP med was changed and they're tolerating. A1C is now 8.2. So already getting a little bit of benefit just from that earlier intervention on their diabetes. They also describe concerns of affording healthy food. They've met with a nutritionist, getting recommendations, and they're saying, I can't afford, healthy, fresh vegetables and such. I buy frozen foods because that's what I can afford. So I put in a referral to our community health workers to help them with those food insecurity concerns. So this is an example of how providing that more comprehensive management that's not just treating their mental illness, but now I've hopefully helped them with their diabetes, their diet, and other concerns. Sample patient without anxiety. This was a patient I had referred to me a number of years ago. Patients referred for new onset anxiety. History of asthma. I look over their med profile. They have, combination inhaler that they're not using regularly, albuterol inhaler that they're using constantly throughout the day, every day, with an albuterol nebulizer once or twice a day, most every day. And their asthma is not doing well. They come in for an in-person appointment and I can physically see them laboring to breathe. Using accessory muscles, the whole chest is heaving up and down, trying to catch their breath. I don't do anything with their anxiety. I counsel them on their asthma medication regimen, about using their maintenance inhaler twice a day regularly. Meet with them later on, and we find that the patient, their asthma is doing better. They're using no nebulizer, less albuterol inhaler, and miraculously their anxiety was decreasing. They weren't having anxiety, they were having low-grade albuterol toxicity. Now, I could have started them on an SSRI and a benzodiazepine and all kinds of other things, but what they didn't need anxiety treatment, they needed med counseling. So this patient was sent back to their PCP, and no further follow-up by me was needed after that initial and one-time follow-up. So what are some quick take-home points? First of all, any new clinical service, you have to address a clear need within the clinic. So for my practice, the rates of mental illness, the need, there was a clear need also for availability of patient appointments because our psych providers were packed to the brim with no availability. So my role was a pretty easy slam dunk. For your own purposes, look for that need in your own clinical setting and find that niche. What is the need for a specialty-based service? It may not be exactly what you want to do. Maybe it's something related, but not exactly what you want. But walk in the door ready to meet the clinic's needs and then develop your own interests as an offshoot as you get established. Use the whole breadth of knowledge that we have as pharmacists. Engage in whole person care, engage in team based care. As I said, I jokingly say I cover the neck up, but I think I gave you some examples of how I look at the whole patient because we need to make sure that that whole patient is getting the care they need and move from being a disease state management, a disease illness focus, to a true comprehensive med management clinic. Provide that whole person, whole body care. Look at the entire patient as you're meeting with them and working on that focused problem in the context of everything going on. I'm going to turn it back over because we're now at the point where we're going to do some breakout rooms. So I will stop sharing my screen.
Yep. Thank you, Rick. Okay. So, thank you both for that presentation. Hopefully some people got some good stuff out of there. I have everybody divided into some breakout rooms with some facilitators. So you'll have about 20 minutes to contemplate some questions, and please feel free to ask questions, share best practices, all of those things, and then we'll reconvene back here to report out and close up. All right. Restart the recording and share my slides again here. Okay. So I think everybody is back. Sorry, I cannot. Oh, here we go. I could not figure out how to see all the participants without losing my slide, but there we go. Okay. So hopefully everybody had a great conversation. What we'd like to do now is just have the facilitators of the groups just recap briefly some highlights from your session, from your breakout room. So we put some ideas. It could be like a key insight or a takeaway or a challenge or a strategy that y'all discussed. So if the facilitators would like to share with the larger group, maybe some highlights from your conversation in our last few minutes here, that would be great. So Rick, do you want to start?
And here I was thinking, oh, I hope someone else goes first. No, that's fine. That's just fine. We had some great conversations, discussions. We got through all the questions that you had sent us to discuss, so that was good. We talked about potential expansion into new areas, expand beyond what a primary care provider can do or is able to do, especially again within that 20-minute visit that they have to try to cover everything. So particularly if you're looking at trying to develop a little bit more of a specialized or focused service, maybe you can dig into that area that the primary care provider doesn't have time for. As far as getting buy-in, definitely the medical director, getting a mentor or champion among the medical staff, trying to get some evidence to provide to the medical staff to show like, hey, this is what we can do. Maybe doing a pilot project to gather that, especially as a resident, as one of the group members mentioned. As far as potential hurdles and ways of getting over them, the first one, and I'm willing to bet most of the groups came up with this one, financial, is finding the money to pay for a clinical pharmacist, especially a brand new service. And we talked about different payment models, whether it's fee for service, value-based care, accountable care. So there are different ways of getting beyond that. We also talked about awareness that a lot of medical providers may not recognize that a pharmacist is more than just someone who fills prescription bottles. So how do we get that awareness and knowledge that, hey, we are clinicians too, we can be part of the team and part of patient care. And then in terms of success, we talked about being able to shift in a successful model that as clinic needs change, maybe you need to change with them and, being willing to maybe adjust what you do, but not taking on too much that it becomes overloaded. And then in a failure, we talked about a change in medical leadership. That if you have one medical director that is very much in favor of a clinical pharmacist role, and a new medical director comes in and says, "What's a clinical pharmacist? Why are we spending money on that?" That success can flip to a failure pretty quickly in that environment unless you can quickly get that new medical director on board. And sometimes even that won't cover it. So those were some of the things we discussed. And hopefully there were some insights and takeaways and strategies that folks, but also potential challenges to consider in your own practice settings.
Awesome. Thank you. Christy, do you want to report out on something real quick here?
Sure. Yeah, we had similar conversations actually. So we actually had one participant in an FQHC, another was a PGY2 resident, and a third was in actually a fee-for-service model. I recently switched to Northwestern Medicine from Advocate Health, which went from like an ACO outcomes-based, value-based to fee-for-service. So we spent a lot of time actually talking about some of the challenges of fee-for-service models and basically lack of reimbursement opportunities. So our group focused on it was it's kind of hard to implement specialty type services when we don't even have the basics, just because fee-for-service models limit billing and reimbursement opportunities as well. And then pharmacists are more expensive than APNs and PAs in our system. So just trying to demonstrate value and kind of where to start to get services started. So we didn't talk too much about non-traditional settings so much as we talked about like buy-in stakeholders and just trying to get off the ground.
All right, thank you. How about in your group, Deanna?
Actually, Bree and I co-led this because we were both in there. So I don't know if Bree was taking notes more than I was. I don't know if she's still on, but
Yeah, I was gonna say that I think we really some people had already touched on financial. We were more so talking about sort of challenges in our specific groups. So really I think for me in a setting of a new startup was more like workflow things and how to do things keep them sustained. Deanna mentioned that a lot of her stuff was tied to if the provider is there, and then if they're not there, she's not able to at least to see them and get like the facility bill. Dan, I might be saying the facility fee. I
yeah,
forgot what you called
facility
it.
fees. Yeah,
Yeah,
facility
facility
fees.
fee.
Yeah.
And so then you're like, well, something is better than nothing. So we kind of talked about that sort of thing, especially in her case where she is having, a wait list. And then we had Amy in our room that is starting up a new service, a new clinic. So more of like what her thoughts are as far as, what kind of things might be barriers and with a startup, more so just like having that patient kind of buy in.
Great. That sounds like great conversation. All right, and last but not least, Anna.
Yeah, our group was similar. We had a lot of different practice types in multiple different states, and all of our states were very different in the legislator and in the legislation on like billing and reimbursement. So that's, I know this wasn't a billing and reimbursement webinar, but that's definitely where our small group kind of ended up at because that was like our main barrier and challenge. And then it kept just hitting that as we work together to federally address some of the billing challenges, and then also maybe just helping educate non-pharmacist team members like in legal and credentialing and that type of thing on like what we're actually trying to do and build out is always helpful. But we really appreciated both speakers and thought that both practices were very nice. And we took parts away that we want to implement, but we're not exactly sure how we could get, a whole FTE covered right away.
That is always the challenge, for sure. Um, All right. Well, with that, we are at our time. So I just want to thank everybody so much for participating today. Thank you to our speakers, Rick and Deanna. I think your insights were invaluable, and it was great hearing about your practices. If anybody would like, this presentation will be posted online. You can reach out if you'd like copies of the slides. I'm speaking for you, Rick and Deanna, but I'm assuming you guys would be okay sharing your slides.
Of course.
Okay, fantastic. Again, just a plug if you are not currently an ACCP member, or you're not a member of the Ambulatory Care PRN, and you appreciated this webinar and want more, please consider joining both ACCP and the AmCare PRN for more. So with that, again, thank you so much to everybody who participated today, and have a good rest of your afternoon.
Thank you.
Thank you.
Thank you.